Hello, my name is Siddharth Kirkray. I'm a transitional year resident at St. Agnes Medical Center, and I'm currently on a psychiatry rotation. So I decided today I'm going to talk a little bit about stress and trauma related disorders. So, trauma and stress related disorders are defined as exposure to a traumatic or stressful event that's listed explicitly as a diagnostic criterion. The DSM-5 recognizes five major classes of trauma and stress related disorders: reactive attachment disorder, disinhibited social engagement disorder, post traumatic stress disorder, acute stress disorder, and adjustment disorders. I'm also going to talk about dissociative disorders as well because even though it's not technically a trauma related or stress related disorder, a lot of them arise in the setting of trauma. And still, any psychiatric condition can be related to trauma or stress. This can be substance use disorder, mood disorders, and then schizophrenia. First one for today is reactive attachment disorder. This is characterized by inhibited and withdrawn social and emotional behavior towards an adult caregiver. It has to be observed before the age of 5, and it's often associated with abuse and neglect, institutionalized care. And here, that's the risk of comorbidities like depression or anxiety. So DSM-5 characterizes this as they're not seeking comfort. There's minimal social and emotional responsiveness. Their affect is limited. They have unexplained irritability, sadness, or hypervigilance. Neurotransmitter changes. There's decreased oxytocin, which reflects the that the child is growing up in an environment of emotional deprivation. That's associated with increased cortisol and ACTH. MRI findings, there's gray matter changes, and Makita et al. In 2020 found higher fractional anisotropy within the neuronal projections in the thalamic region. So, fractional anisotropy is used in diffusion tensor imaging. Diffusion tensor imaging analyzes the water movement of white matter tracks, and so fractional anisotropy provides a measurement of asymmetry. So, anytime you see that, just think they're talking about white matter. DSM-5 criteria for reactive attachment disorder. So they've had to have the pattern the child's not seeking comfort or they're not responding to comfort from adult caregivers. There's minimal social and emotional responsiveness. Their positive affect is limited. They've had episodes of unexplained irritability, sadness, or fearfulness. That's evident even during non-threatening interactions with adult caregivers. The child's experienced a pattern of extremes of insufficient care. They haven't had their emotional needs or social needs met by their caregivers. This is also very common in children who go to foster care, where there might not only be there's repeated changes of primary caregivers, so that makes it very difficult to form stable attachment. And then there's unusual settings, like maybe there's a high child to child caregiver ratio. They can't create good selective attachments. They don't meet autism spectrum criteria. It has to be observed before the age of 5. The child has to have a developmental age of 9 months. Some hypotheses that have been proposed in reactive attachment disorder. This is most likely multifactorial, including trauma, high child to caregiver ratio, parent with either a psychiatric condition or a medical condition. There's the mediation hypothesis. Child doesn't have a good trust relationship with their caregiver, and that reflects a weak attachment. But a few studies haven't revealed an association between the degree of caregiver child attachment and the occurrence or severity of these symptoms. There was another study done by Zena and Gleason that found that enhanced caregiving was associated with better outcomes in reactive attachment disorder. The attachment theory was described by Bosmans in 2020, and then an increase in attachment can lead to a child feeling more secure. And it was also noted that even if the attachment and security with teachers had a temporary role, it was still important. There's the dynamic model of insecure cycle. So that was proposed by Kobach and Bozeman in 2019. That described an innate attachment system in children that needed to be nurtured. And if that was learned, that could be permanent in children. This was associated with poor attachment that created negative memories, and then that could lead to support seeking behavior and maybe even maladaptive coping mechanisms. So, there was a study in South Korea that looked for the medical and psychiatric comorbidities in children with reactive attachment disorder. So, in children age 0 to 3 and 4 to 6, typically what was most observed was language. There was also enuresis or encopresis. What I found very surprising is that typically we think of schizophrenia as presenting in 15 to 25 in males and then 30s in females, but actually this was observed, schizophrenia was observed in children with reactive attachment disorder earlier on in this study. At age 7 to 9, there was a higher risk of conduct disorders, severe stress reactions, adjustment disorders, and tic disorders. And then I thought it was pretty interesting that respiratory system disorders were associated the most with reactive attachment disorder. Management, so behavioral and psychosocial problems need to be addressed. There are attachment-based therapies. There's holding therapy, which is or reduction therapy, where there's prolonged restraint and exposure to noxious stimuli. The child no longer attempts to avoid the stimulus, and then the child returns to the caregiver. But this is less preferred because this is a high risk of physical injury for the child. Behavior management training is preferred because it involves the caregiver. And then this creates goal and direct behavior directed therapy. So there's psychoeducation given to the caregivers, parenting skills. A home-based reward system was actually found to improve school performance. And was especially successful in children ages 6 to 11. The pharmacology hasn't been studied as well, but there have been case reports of two children with disinhibited reactive attachment disorder. They improved with sertraline. And then children with reactive attachment disorder might have special educational needs as well. Disinhibited social engagement disorder. So I like to think of this as the opposite of reactive attachment disorder. Criteria is still the same, has to present early in life. Child must have a developmental age of at least 9 months. It was an environment of deprivation for them where they grew up, but the difference is that there's no stranger danger for them. They show they're willing to approach and interact with unfamiliar adults. It's not consistent with their culturally sanctioned or age appropriate boundaries. And then they wander off on their own. They don't necessarily check back with their caregiver, even if they're in a new place. This is also associated with reduced competence in adolescents. There hasn't been any strong, robust evidence for definitive treatment, but caregiving quality has been associated with an improved prognosis. Adjustment disorder. So, this is maladaptive emotional or behavioral responses to an identifiable psychosocial stressor. Captures those who experience difficulties adjusting after a stressful event at a level disproportionate to the severity or intensity of these stressors. It has to be within 3 months of the onset of the stressor, and it has to be out of proportion to the stressor. So, unlike PTSD, this does not have to be, the stressor does not have to be traumatic. All it needs to do, like, it just needs to be something that causes a lot of distress and impairment in the social or other functioning. And then once the stressor or its consequences have terminated, these symptoms don't persist for more than 6 months. So there's common specifications on the DSM-5 that include depressed mood, anxiety, mixed anxiety and depressed mood, disturbance of conduct, and then there's an unspecified one, and that's for maladaptive reactions that are classifiable as one of the specific subtypes of adjustment disorder. It's not easy to diagnose with the standard screening tools, but there have been some new tools, such as the diagnostic interview for adjustment disorder that uses DSM-5 criteria, try to identify symptoms associated with the stressor. and then a level of distress and functional impairment. But it's only been proposed by one author and it's not been externally validated in other studies. There's the adjustment disorder new module where there's a list of stressors like acute and chronic life events that have been present in the past year, asking what's the most prominent or distressing. And then there's another part that talks about that assesses the patient, how the patient responds to the stressors. Are there preoccupation with them, failure to adapt, avoidance, etc.? So treatment was there was a systematic review in 2018 that assessed 29 treatment trials that investigated the current options for psychological and pharmacological intervention. It's a low or very low quality of evidence in these studies, but there was one trial, a brief adjustment disorder intervention that was self-help, and then there was another trial that compared face to face with virtual reality, but these have had small sample sizes and then higher dropout rates. So assessing them has been a little bit harder. Moving on to dissociative disorders, so DSM-5 classifies them as disruption of or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. This isn't technically a trauma disorder, and DSM-5 doesn't include them in trauma-related disorders, but I'm talking about them here because they often arise after trauma. Dissociative identity disorder, that's a disruption or discontinuity in the normal integration of consciousness, memory, identity, perception, body representation, motor control, behavior. Depersonalization, derealization disorder, that's when they feel like they're detached from their body or from their reality. That's causing a lot of distress for them. And their reality is intact. Dissociative amnesia, so they can't recall important autobiographical information. This is tested on exam sometimes as dissociative fugue, where there's sudden unexpected travel or wandering in a dissociated state. There's dissociative amnesia for that episode. So diagnostic criteria for dissociative identity disorder, disruption of identity, two or more distinct personality states. Some cultures might describe this as an experience of, oh, you're possessed or something. There's marked discontinuity in the sense of self and the sense of agency. There's alterations in affect, behavior, consciousness, memory, perception, cognition, and sensory motor functioning. These might be observed by others or reported by the individual. There's gaps in the recall of everyday events, and it's just not consistent with ordinary forgetfulness. And the symptoms have to cause clinically significant distress or functioning, impairment in functioning. And it's not a part of cultural religious practice. So children often have imaginary friends. That's not, that on its own will not meet criteria for dissociative identity disorder. And these symptoms, you have to rule out substance or medical use like seizures. Pathogenesis, um, typically there's the trauma or stress diathesis model. So individuals with the predisposition to the illness who experience a major stressor. There's some genetic or other biologic factors as well, such as dopamine, neuron repair, neuron growth and repair, glucocorticoids, serotonin transport. Neuroimaging studies, they haven't been very consistent, but there have been some associations I observed with smaller hippocampal and amygdala volumes. There could be childhood trauma, poor infant bonding, sexual, physical abuse is a risk factor, and that's commonly tested on examinations. There's the sociocognitive model in which the individual symptoms represent a role enactment consistent with cultural and interpersonal manifestations. So, clinical manifestations, they could have disruption of their identity characterized by presence of two or more distinct personality states and recurrent gaps in recall. And then there's amnesia, depersonalization, derealization, self-alteration, or and something like a trance state. And then the course can be fluctuating. And I'm not sure why this is highlighted, but okay. Depersonalization and derealization disorder. So there's feeling of detachment with respect to oneself and or feeling of detachment with respect to the surroundings. So reality testing's intact. And then again, you have to rule out medical conditions or substances or medications, as well as other disorders. So pathogenesis, again, through the trauma model, acute symptoms can cause acute depersonalization and derealization. Chronic trauma can cause chronic depersonalization and derealization. So seizures, head injury, brain tumors, sleep apnea, and substance use have also been implicated. From a neurological, neurobiologic standpoint, so ketamine is a known antagonist of NMDA, and that produces a dissociative state in healthy patients. Cannabinoids are also NMDA blockers, but it's at a different site than other non-competitive inhibitors, and it's known to induce dissociative effects in healthy patients. Salvia is which is an illicit drug. It's a selective kappa opioid agonist that precipitates chronic depersonalization. Naloxone and naltrexone are associated with acute depersonalization. Serotonin agonists, like hallucinogens, have been implicated. Autonomic instability, as well as HPA axis, have been implicated. Sensory integration occurring in the temporoparietal junction has been noted on PET, while hypoactivation of the limbic system has been noted on functional MRIs. And the retrosplenial cortex is one area implicated in dissociation as well as other findings. So the workup for depersonalization and derealization disorder, they need psychiatric history, medical history, mental status examination, and as well as a cursory physical exam. So if they're over 40, there's focal neurological deficits, head injury, seizure, sleep apnea, autoimmune disease, family history of neurological conditions, or suspecting atypical symptoms or infectious etiology, get an MRI, EEG, and BMP. UTOX if substance use is part of the history, and then dissociative experiences scale can be used for screening. For dissociative amnesia, here's the diagnostic criteria. So they can't recall important autobiographical information. It's usually traumatic or stressful nature. It's not associated with ordinary forgetting. There's clinically significant distress or impairment in social, occupational, or other important areas of functioning. Not attributable to the physiologic effects of a substance or a neurologic or other medical condition. And it's not better explained by dissociative identity disorder, PTSD, acute stress disorder, somatic symptom disorder, or major or minor neurocognitive disorder. And then there's a specifier with dissociative fugue, like apparently purposeful travel or bewildered, wandering, associated with that trance state, amnesia for identity or for other autobiographical information. So we're going to move on to acute stress disorder and post-traumatic stress disorder. So whether it's a USMLE exam or an actual patient, the timing is everything. Acute stress disorder is less than 1 month from the identifiable stressor or traumatic event. Post-traumatic stress disorder, that's either the symptoms arise after a month or they could have arisen within the that month. They could have arisen before that month, but they persist after a month. So here's the DSM-5 for PTSD. So there's actual or threatened death, serious injury, or sexual violence. So they directly experience it, they witness in person, they learn that the traumatic event occurred to family or friends, and then that has to be violent or accidental if that's the case, and then repeated or extreme exposure to aversive details of traumatic events. So DSM-5 has some examples DSM-5 gives are first responders that collect human remains or police officers repeatedly exposed to details of child abuse. So there needs to be some intrusive symptoms after the traumatic event, like recurrent, involuntary, intrusive, distressing memories of the traumatic event, dreams that are related to the traumatic events, flashbacks or other dissociative reactions the individual feels or acts if the traumatic event was recurring. There's intense or prolonged psychologic distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic event. And then there's marked physiologic reactions to internal or external cues that symbolize or represent an aspect of the traumatic event. There's more, so they have to be avoiding the stimulus. Like, say, for example, someone might have been in a car accident. They don't want to drive across the bridges, or they might avoid that intersection, or they might not even want to get in a car. Maybe they just want to walk everywhere. There's negative alterations in the cognition and mood that's associated with the traumatic event that could either begin or worsen after the traumatic event. There's two or more of these, so they can't remember an aspect of it, like whether they're that could either be dissociative amnesia and not because of like head injury, alcohol, drugs, or other factors. There's persistent and exaggerated negative self belief, or I am bad, the world is dangerous, things like that. There's persisted distorted cognitions about the cause or consequences of the traumatic event that lead the individual to blame themselves or others. There's a persistent negative emotional state, maybe markedly diminished interest or participation in significant activities, feelings of detachment or estrangement from others, and then a persistent inability to experience positive emotions. Like they can't feel like I don't deserve happiness or I don't experience happiness. And then there's marked alterations in arousal and reactivity that's associated with it. So they might be having irritability or angry outbursts without provocation towards people or objects. They're hypervigilant, like there's a loud noise, they start looking over their shoulder. Um, Reckless or self-destructive behavior, maybe some problems with concentration, and then sleep disturbances are commonly cited. Again, more than 1 month. If it's less than 1 month, it's acute stress disorder. And it's not attributable to the physiological effects of like medications, alcohol, other substances, or medical conditions. I'm sorry, I don't know why this was highlighted too much, but I can't change the theme. All right, whatever. But the important thing to note is that with regards to the important thing to note with acute stress disorder is that it's the result of or it's under 1 month, sorry. So we'll do some risk factors for PTSD. So risk factors for acute stress disorder, they're very similar to PTSD. There's could be history of a pre-trauma psychiatric disorder. Maybe they've had a history of traumatic exposures prior to the recent one. Female, the severity of the trauma, they've had distress around the trauma, neuroticism, low social support, as well as avoidant coping. Then pathogenesis associated with dissociative symptoms, panic, elevated arousal, and then cognitive processing. So the prevalence of PTSD, that could be 6.1 to 9.2% in adults. Pathophysiology, so there's the initial response to trauma, that's a sympathetic activation. And then there's further neuroendocrine responses. If there's a prolonged or repeated trauma stimulus, there could be a conditioned behavior therapy response. Amygdala is what recognizes threat. It handles fear and emotion. Normally, the frontal cortex will act against that to try to tone down that stimulation, but it's hypothesized that downregulation of this counteractivity by the frontal cortex can lead to acute stress disorder and PTSD. MRI findings can be mixed, but generally, most studies have found them to be nonspecific. So, the important history in physical, so there's a history of trauma. They might have dissociative features. Ask about how much does the patient think about the event, how disturbing it is. Do they experience nightmares? Are they avoiding their triggers? The physical exam's typically nonspecific, but tachycardia, hypertension, muscle tension, or disrupted sleep patterns might be observed and show evidence of sympathetic hyperactivity. Mental status examination is really important in making the diagnosis. It can assess them. Maybe they might have scars or other wounds or whatever. They might have hypervigilant behavior, check to see their eye contact. They might look their affect might be fearful, anxious, apathetic, or depressed, and it can change. The range of affect should be observed, and then they might just be feeling numb as well. So be on the lookout for that. Assess thought content to assess for suicidal ideations and self-harm behaviors. Thought process, if they have persistent and negative, exaggerated beliefs after trauma, the thought process might not be linear. Most patients with PTSD they have very good insight into their conditions, but they also are known to minimize their symptoms as well. They might have difficulty understanding how PTSD symptoms could relate to depression, substance use, and other psychiatric comorbidities. Assessing their judgment, what's their clinical presentation, what's their ability to make rational decisions based on their treatment plan options. The most important part of the workup is a psychiatric evaluation. Labs tend to be less useful in this case, but it's more important to assess stressor, intrusive symptoms, avoidance, negative changes to the mood, change to their arousal and reactivity. Remember, lasting longer than a month, it has to cause functional impairment or distress. It's not attributable to medical, and it's not attributable to medical illness, substance use, or medication. Trauma-focused psychotherapy is first line. So that includes cognitive behavioral therapy, exposure therapy, which is re-exposure to the traumatic stimulus. That does require patient consent, and it also requires good follow-up from them. Eye movement desensitization and reprocessing therapy. So, saccadic eye movements reduce the intensity of disturbing thoughts, and it has been shown to desensitize traumatic memories, improve the validity of a positive self-belief, but neurobiologically, the mechanism's unknown. There was a study performed in 2019. One group was able to choose their treatment, either exposure therapy or sertraline, and then there was the other group, they didn't have a choice of their treatment. Most patients preferred a prolonged exposure to sertraline, interestingly enough. And that might have been why, but even after contributing for that prolonged exposure, it was significantly more likely than sertraline to lose their PTSD diagnosis and obtain responder status. So for pharmacotherapy, SSRIs are first line and FDA approved. Sertraline and paroxetine are most commonly used. SNRIs could be used off label. For nightmares, um, alpha 1 blockers like prazosin or clonidine have been used. The literature is inconsistent about how much I couldn't find too much. Some studies says there was benefit, other studies said no, but if you're a medical student reviewing this, it's very commonly asked on USMLE step exams. Quetiapine showed efficacy as a monotherapy in veterans as well. Differential diagnosis of PTSD. So there's acute stress disorder, timing, timing, timing. Dissociative disorders are in the differential major depressive disorder, adjustment disorder, and other psychiatric disorders. So the prognosis is better if it's treated. Positive psychology emphasizes psychological resilience. So that creates positive changes in self-perception, interpersonal relationships, and philosophy of life that can co-occur or that can occur in individuals who recover from trauma and PTSD. Chronic PTSD, it lasts longer than a year, observed in a third of patients with PTSD. Prevention and deterrence, so that minimizes the impact of traumatic events and mitigates the development of persistent psychological distress. So, primary prevention is about promoting resilience, coping skills, and social support networks in patients. Whereas secondary prevention, you would be screening for possible PTSD and then quickly act quickly act. For children and adolescents, it's hard enough to make the diagnosis in adults. It's even harder in children and adolescents. Trauma is really prevalent in youth. I think USA census showed 62% had at least one traumatic event. In Mexico, 69%. Males are more likely to experience physical violence, whereas females are more likely to experience sexual violence, but anyone could theoretically be exposed to both. So, physical and sexual violence is a major risk factor. 30 to 70% of children exposed to violence may develop PTSD. If they witness the violence, physical assault by a non-family member tends to be more common in adolescents, automobile accidents, war and disaster, alcohol or drug use, either by self or by family, many more risk factors, and then urban environment. It's twice as more common in females as it is in males. From studies in the US, poor prognostic factors include lower income, having co-occurring bipolar disorder, or experiencing additional traumatic events after the trauma that triggered the onset of PTSD. So, focus on intrusive thoughts, strong reactivity to trauma cues, nightmares, repetitive play, avoidance of trauma reminders, and hypervigilance. Suicide risk assessment is even more important in pediatrics. UCLA PTSD Reaction Index for children and adolescents is a screening tool that evaluates trauma exposure as well as DSM-5 and then functional impairment convergent validity. So, looks for the types of distinct trauma, the continuous symptom severity score, and then tries to make a PTSD diagnosis. Clinician administered PTSD scale for children and adolescents. That's trauma exposure and then symptom severity score, frequency, and intensity. Lower thresholds are used for children under the age of 6. Trauma focused psychotherapy is preferred. And what I found interesting is that the only evidence that SSRIs provide benefit is if the patient also has coexisting depression or anxiety. It's not that it hasn't provided benefit in PTSD without those symptoms or without those coexisting conditions. Prazosin for nightmares, and then clonidine or guanfacine for hyperarousal. And remember, these are all alpha 1 blockers. Or, sorry, no, prazosin is an alpha 1 blocker. Clonidine and guanfacine are alpha 2 agonists. So, on a step exam, they might ask the mechanism of action for that. And then here are my references. That concludes. Thank you.